Welcome back to another deep dive. Today we're wading into some pretty murky waters.
Oh yeah, murky is definitely the right word for it.
We're talking about creatures that treat the human body like a rental property where they refuse to pay the lease and occasionally just trash the furniture. We are talking about parasitology.
It's a subject that I think definitely triggers a visceral reaction. For most medical students, there's this initial wave of just pure disgust.
The creepy crawlies?
Right, the idea of worms and creeping things inside you. And then that's followed almost immediately by a wave of panic because the sheer volume of taxonomy feels completely overwhelming.
Yeah, you're looking at protozoa, nematodes, astodes, trematodes.
Exactly.
Yeah.
It feels like you're memorizing a phone book written in Latin.
It really does feel like this chaotic list of bugs. But our mission for this deep dive is to bring order to that chaos for you. We are decoding Murray's Medical Microbiology, Chapter 68, which focuses specifically on the pathogenesis of parasitic diseases.
Which is such a crucial chapter. We aren't just listing bugs today. We are building a structural mental model of host pathogen warfare.
Right, and we'll be fleshing out some of the specific organism details from Jaywitt's Chapter 46 to supplement Murray. We want this to be a high-yield framework specifically designed for exam retention, so single best answer and MCQ focus.
That's the core goal here, to understand the rules of engagement. Because if you can understand the strategy of the parasite, how it invades, how it survives, and how it accidentally hurts us, you don't need to memorize that Latin phone book.
You can just derive the answer.
Exactly. Deriving the mechanism beats rote memorization every single time.
I love that. So let's start with the big picture. How does a parasitic infection differ from, say, a bacterial infection? Because we've covered bacteria before, and they usually seem pretty aggressive.
That is the key distinction to make right out of the gate. If we look at a classic bacterial pathogen like Staphylococcus or Streptococcus, they're often like arsonists.
They just break in.
They break in, they replicate explosively, they release toxins that destroy cells instantly, and essentially try to burn the house down before the immune system and police can arrive. It's a smash-and-grab strategy.
Subtlety is definitely not their strong suit.
Not at all. But parasites. Parasites are playing a much, much longer game. Like you said earlier, they're the ultimate squatters. Evolutionarily, it makes absolutely no sense for a parasite to kill its host quickly.
Because if the host dies, the parasite dies?
Precisely. So their goal is to move in a specific organ to suit their needs and stay for decades without getting evicted.
So the goal isn't destruction at all, it's coexistence.
Yes, it is about equilibrium. That is the central theme of Murray Chapter 68 that I want you to anchor in your mind. Parasitic disease is rarely about rapid fulminant destruction. It is almost always about chronicity.
Okay, but if they want to coexist and just be quiet squatters, why do we get sick? I mean, why are we even studying them if the perfect parasite is invisible?
Well, that's the catch, right? Disease happens when that equilibrium tips. And it usually tips in one of two ways. One, the parasite gets too greedy, it reproduces too much, it physically blocks an organ, or it steals too many nutrients. Or two, and this is really the big one, the host overreacts.
Our own immune system causing the pathology.
Exactly. A massive amount of parasitic pathology is actually immune-mediated. It's the body's clumsy attempt to evict the squatter that ends up destroying the plumbing and the drywall.
So as we go through this, you should be constantly asking yourself, is the damage caused by the bug or is the damage caused by the host's reaction to the bug?
That is exactly the framework.
Perfect. So we are going to structure this deep dive chronologically based on Murray. We'll look at the invasion, then the mechanisms of direct disease, and finally that immune-mediated pathology. So let's start at the beginning. Part 1, the invasion, getting through the door.
Right. To establish an infection, a parasite has to breach the body's defenses first. And broadly speaking, we can categorize these into three main strategies. I like to call them the Trojan horse, the barefoot Contessa, and the Uber driver.
Okay, I have to ask about the Trojan horse first. I assume this involves trickery.
It does. This is ingestion. It's passive entry. The parasite is basically lazy. It waits for the host to make a mistake. And usually that mistake is eating or drinking something contaminated with fecal matter.
Which brings us to the very first major hurdle for any pathogen entering the body, the stomach.
Yes. The stomach is a vat of hydrochloric acid. It is an incredibly hostile environment designed to sterilize what we eat. Most biological organisms just dissolve in there. So for a parasite to survive ingestion, it needs a spacesuit.
And in protozoa, those single-celled organisms, that spacesuit is the cyst form.
Yes, this is an extremely high-yield concept for exams. You absolutely have to differentiate the cyst from the trophozoite. The cyst is the infectious form. It's metabolically inactive. It has a very thick wall, often containing chitin or similar resistant polymers, and it acts like an armored tank.
You eat the cyst.
You eat the cyst, and it just laughs at the stomach acid.
And the trophozoite.
The trophozoite is the delicate soldier inside the tank. Once the cyst reaches the alkaline environment of the small intestine, it senses the change in pH, and it exists. The tank opens, and the trophozoite emerges.
And that's the active form.
Right, the trophozoite is the motile feeding, replicating form. But it is fragile. If you swallowed a trophozoite directly, your stomach acid would obliterate it instantly.
So if I'm reading an exam case study and the patient drank from a mountain stream, they ingested cysts.
Correct. Take Giardia lamblia or Entamoeba histolytica. Both follow this exact rule. You drink water that looks pristine, but a beaver upstream has contaminated it. You are swallowing Giardia cysts.
Why is it always beavers in these questions?
They are the classic reservoir host in North America, hence the name beaver fever. But the mechanism is the same for Entamoeba. Ingest the cyst, exists in the gut, and then the trophozoites start doing their work.
Does this cyst versus trophozoite model apply to worms, too?
It's a very similar concept, but we use different terminology. For helminths or worms, the spacesuit is usually the egg. We call this the fecal-oral route. A classic example is Ascaris lumbricoides or Trichuris trichiura, which is the whipworm.
So you ingest the embryonated eggs from contaminated soil.
Exactly, or contaminated food. The shell protects the larvae until they reach the gut where they hatch.
I want to zoom in on Enterobius vermicularis here, the pinworm, because this one feels like a total cheat code. It doesn't even wait for contaminated water or soil. It just creates its own tight little cycle.
It really does. Pinworm is the most common helminth infection in the U.S. and Europe, largely because of how incredibly efficient its transmission is. It relies on autoinfection.
Walk us through that mechanism because it's so testable.
So the adult worms live in the cecum. At night, the pregnant female worm migrates down the colon and actually slips out of the anus to lay her eggs directly on the perianal skin. And she uses this sticky substance to glue the eggs right there.
Which is obviously irritating.
Extremely. It's intensely pruritic, itchy. So the child scratches their bottom while they're sleeping. The eggs get lodged under their fingernails. Then inevitably those fingers go back into the mouth.
And the cycle just restarts immediately.
Right, you were reinfecting yourself. Plus, those eggs are very light, they can get on bed sheets, they become airborne, and they can be inhaled or swallowed by everyone else living in the house.
And the diagnostic test for this is low-tech but iconic.
The Scotch tape test, or cellophane tape test. You literally touch the sticky side of the tape to the perianal skin first thing in the morning before the child bathes. The eggs stick to the tape, and you stick that to a slide and look at it under a microscope.
So if you see an exam question about a restless child with an itchy bottom, think pinworm and Scotch tape.
Every single time.
Okay, so that's the Trojan horse. Passive entry via ingestion. Now let's move to your second category. The barefoot contessa. This implies the parasite is entering through the feet.
Yes, this is active invasion. The parasite is not waiting for you to eat it. It is actively hunting you. We are talking about soil-transmitted helminths like the hookworms and Silostoma duodenale and Necator americanus, and also Strongyloides stercoralis.
Honestly, this sounds like a sci-fi horror movie. How does a microscopic worm in the dirt know where my foot is?
They have incredibly sophisticated sensory organs. The larvae in the soil are thigmotactic, meaning they are sensitive to touch, and thermotactic, meaning they sense heat. They can actually sense the warmth of your foot and the carbon dioxide you are emitting.
And when you step on the soil,
they latch on.
and then they just drill into you.
Pretty much. They secrete specific enzymes like hyaluronidases and proteases that chemically dissolve the connection between your skin cells. They bore right through the intact epidermis.
Does the host feel that happening?
Often, yes. Clinically, this presents as ground itch. It's a localized pruritic papular rash right at the entry site, usually between the toes or on the ankles.
So if an exam scenario mentions a patient who likes gardening barefoot or maybe walking on a beach in the tropics, my alarm bell should be ringing?
Absolutely. Hookworm or strongyloids. But we really need to make a critical distinction here between those two. Hookworms enter the skin, migrate to the lungs, get coughed up and swallowed, leaving the gut, and then lay eggs that go out with the stool.
Right, so that's a linear cycle.
Yes. But strongyloids breaks the rules entirely.
Strongyloids is the one you called the supervillain earlier.
It is a supervillain. It has a superpower called autoinfection, just like the pinworm. But it is so much more dangerous than the pinworm version.
How does autoinfection work differently for strongyloids?
Normally, helminth eggs need to leave the body to mature in the soil. They need environmental oxygen and time to become infectious. Strongyloids is different. The eggs hatch inside the host's intestine into larvae.
Okay, so now you have live larvae in the gut.
Right. And usually these are the non-infectious rhabditiform larvae. They just get pooped out.
Yeah.
But sometimes they transform inside the colon into the infectious filariform larvae.
Oh, wow.
Yeah. These infectious larvae can then penetrate the bowel wall right there from the inside, enter the bloodstream, and restart the entire migration cycle without ever leaving the host.
So unlike hookworm, where if I don't step on new contaminated soil, the infection eventually just dies out of old age, with strongyloids, it can just keep infecting me forever.
Exactly. We have perfectly documented cases of World War II veterans having active strongyloids infections 50 or 60 years after they left the South Pacific.
Yeah.
It is a lifelong persistence.
And why is this clinically terrifying? Why is it a supervillain?
Because of the why. Why did the body normally keep this in check? The immune system, specifically T cells and eosinophils, usually keeps the number of auto-infecting larvae relatively low. You might have mild symptoms, but you survive.
But if that patient becomes immunocompromised.
Exactly. Say they get high-dose steroids for an asthma exacerbation, or they start chemotherapy, or they catch HTLV1. The immune brakes just completely come off.
And the autoinfection cycle accelerates.
It goes into absolute overdrive. We call it hyperinfection syndrome. You have millions of larvae penetrating the bowel wall all at once. And here is the kicker. They aren't sterile. As they bore through the gut wall, they drag enteric bacteria like E. coli directly into the bloodstream.
So the patient actually presents with sepsis.
Gram-negative sepsis, meningitis, and pneumonia all caused indirectly by a worm. It has a massive mortality rate.
That is a crucial mechanism to understand for exams. Hookworm equals anemia. Strongyloids equals this lifelong danger of hyperinfection syndrome.
You got it. That's exactly how they'll test it.
All right, let's move to the third invasion method, the Uber driver.
Arthropod vectors. This is the parasite bypassing the skin defenses entirely by using a flying syringe.
This category includes some of the absolute biggest killers in human history.
Without a doubt. Malaria or Plasmodium is the prototype here. The Anopheles mosquito literally injects sporozoites directly into the capillary bed while it's taking a blood meal.
It's incredibly efficient.
Very. But there are nuances in the Uber driver category that are high yield. Not every bug injects the parasite through its saliva.
Wait, really? I just always thought the bite itself was the transmission.
For malaria and filariasis, yes. The saliva injects the parasite. This is called anterior station transmission. But let's look at Chagas disease caused by Trypanosoma cruzi. The vector here is the reduvid bug, also known as the kissing bug.
Why is it called the kissing bug?
Because it likes to bite you on the face, usually near the lips or eyes while you're sleeping. It's attracted to the carbon dioxide you exhale. But here's the gross part, and this is high yield because it's so distinct. The bug doesn't inject the parasite. The parasite actually lives in the bug's hindgut.
I think I see where this is going, and I don't like it.
The bug bites you. It feeds on your blood, and because it gets so full, it defecates right next to the bite wound. The bite itself is very itchy, so you wake up, you scratch the bite, and you essentially rub the infected feces directly into the open wound or accidentally into your eye.
That is truly disgusting.
It is. But that mechanical difference, posterior station transmission via poop versus anterior station transmission via saliva, is a classic board exam differentiator.
Okay, so we are inside. The invaders have breached the castle walls. They've either tricked us into eating them bored through our feet or hitched a ride on a bug. Now we move to part 2, mechanisms of disease. The parasite is inside the house. How does it actually cause damage?
Murray divides this into 2 main categories, direct damage, which we can call the bull in the china shop, and nutrient competition, which is the thief.
Let's start with direct damage. Who is the biggest bull in the china shop?
Entamoeba histolytica. The name literally tells you the exact mechanism. And for enteric or gut, amoeba histo meaning tissue, and lytica meaning dissolving. It is the tissue dissolver.
How does a single microscopic cell dissolve human tissue?
It has a very specific virulence factor. A galactose and acetylgalactosamine lectin. I know that's a mouthful. But basically, it's a molecular grappling hook that allows the amoeba to adhere tightly to the colonic epithelial cells.
And once it's locked on,
Once attached, it secretes powerful cysteine proteinases that literally seize the host cells and digest the extracellular matrix.
it just eats the glue holding the intestinal cells together.
Exactly. And this creates a very specific pathognomonic lesion that you'll see on exams, the flask-shaped ulcer.
We hear this term flask-shaped ulcer all the time. Can we unpack the physics of it? Why does it form a flask shape?
Think about the anatomy of the gut wall. You have the mucosa on top, which is pretty tough and densely packed, and the submucosa underneath, which is looser and highly vascular. The amoeba punches a small, narrow hole through that tough mucosa. That's the neck of the flask.
But once it gets through that top layer,
Once it hits the looser submucosa, it finds way less resistance, and it just spreads out laterally, creating a wide, broad base of necrosis.
so broad destruction underneath a tiny little opening.
Right. And because they are now down in the submucosa, they have direct access to the blood vessels. They can erode right into the portal circulation and take a free ride straight to the liver.
Leading to the dreaded amoebic liver abscess.
Which brings us to our next gross food analogy for medical school. If you stick a needle in that amoebic liver abscess to drain it, the pus isn't your typical white or yellow bacterial pus. It's a reddish-brown necrotic slurry that is universally described as anchovy paste.
Anchovy paste. Disgusting, but absolutely impossible to forget. Okay, so entamoeba melts tissue. What about malaria? That's also direct damage, but it's intracellular, right?
Yes, Plasmodium falciparum is what I call the cell burster. It infects red blood cells, it turns them into parasite replication factories, and then it violently ruptures them. But the rupture isn't random, it's synchronized.
And that synchronization is why the fevers are cyclic.
Exactly. Every 48 hours for tertian malaria like falciparum, a massive coordinated wave of red blood cells ruptures simultaneously. They dump toxins, parasite waste, and new merozoites into the blood all at once. That sudden massive antigen release triggers the rigorous shaking chills and high fever spikes.
But falciparum is notoriously worse than the other malaria species like Vivax or Ovale. It kills a lot of people. Why is its direct damage so much more lethal?
Because it doesn't just burst cells, it actively modifies the ones it infects before they burst. It inserts a parasite protein called PFEMP1 onto the outer surface of the infected red blood cell. And this protein acts like Velcro. Specifically, it binds to receptors like ICAM1 on human endothelial cells.
So the red blood cells literally become sticky.
They stick to the walls of the capillaries and they stick to each other, which is a process called rosetting. This physically clogs up the microcirculation. We call this sequestration.
Why does the parasite want to do that? Why get stuck in a tiny capillary?
To avoid the spleen. The spleen is the body's blood filter. It's designed to recognize and remove abnormal red blood cells. By making the cells stick to the vessel walls deep in the brain, or the kidneys, the parasite avoids getting swept into the spleen and destroyed.
Wow, so it's a pure survival tactic.
It's brilliant for the parasite, but it is devastating for the host. If this microscopic jamming happens in the brain capillaries, you get cerebral malaria. That leads to ischemia, coma, and death. If it happens in the lungs, you get severe pulmonary edema.
Okay, so we've got entamoeba dissolving tissue and malaria bursting cells and clogging vessels. Let's talk about the thieves now. Nutrient competition.
This is a classic parasitic strategy. Eat your lunch before your body has a chance to absorb it.
What are the high-yield nutritional deficiencies we absolutely need to know?
Number one is definitely Diphyllobothrium latum, the fish tapeworm. This is a massive worm. It can grow to be 10 meters long inside your gut, and it has a frantic-specific affinity for vitamin B12.
It just steals the B12 right out of the intestinal lumen.
Yes. It actually dissociates the B12 from the host's intrinsic factor complex and absorbs huge amounts of it for its own metabolism.
So logically, the patient presents with severe B12 deficiency symptoms.
Right. Megaloblastic anemia, where you have those abnormally large red blood cells, and crucially neurological symptoms like paresthesias, numbness, or balance issues, because B12 is essential for maintaining myelin on your nerves.
So if you see a patient who loves eating raw freshwater fish, maybe they make their own ceviche or eat wild-caught sushi, and they have megaloblastic anemia, it's the fish tapeworm.
Exactly. Now, what about hookworms? We mentioned them as invaders earlier, but how do they feed once they're inside? Hookworms are the vampires. They latch onto the intestinal mucosa with these literal cutting plates or teeth, but they don't just take a bite and leave, they want to keep the blood flowing. So they secrete powerful anticoagulants.
So the host bleeds continuously from the bite site.
Even after the worm detaches and moves to a new spot in the gut, the old bite site just continues to bleed and ooze. This leads to profound chronic blood loss over months or years.
Resulting in
Iron deficiency anemia, microcytic anemia. If you have a vignette about a child in a developing nation with severe fatigue pallor and microcytic anemia, hookworm should be at the very top of your differential diagnosis.
And there's one more thief we need to cover, Giardia. It doesn't suck blood and it doesn't steal B12.
Right. Giardia is what I call a blockade. The trophozoites have this large ventral sucking disc. It acts like a powerful suction cup. They use it to attach directly to the microvilli of the small intestine. But they don't invade the tissue, they just sit there.
Like a carpet over the mucosa.
Exactly. They literally pave the small intestine. This creates a physical barrier. Nutrients, especially fats, simply cannot reach the absorptive surface of the human cells. Plus, the sheer mechanical trauma of the attachment blunts the villi and destroys the brush border enzymes like lactase.
So the patient suddenly becomes lactose intolerant and they completely lose the ability to absorb dietary fat.
Resulting in steatorrhea, copious, fatty, floating, foul-smelling stool that is notoriously hard to flush.
No.
And they'll have significant weight loss because they are literally starving despite eating normally.
That is a great mental model, the dissolvers, the bursters, and the thieves. Now let's move to part 3, mechanical obstruction, the traffic jam.
This is where the sheer physical size or the massive number of parasites becomes the primary mechanism of disease.
I always think of Ascaris lumbricoides here, because these are genuinely big worms.
They are. They're roughly the size of a large earthworm or a standard pencil. And they are gregarious, meaning they like to physically clump together. If a child has a heavy burden, say, hundreds of worms living in their gut, they can tangle together and form a literal knot, a solid bolus that completely blocks the ileocecal valve.
It's a true mechanical bowel obstruction.
Yes, surgical emergency. But there is a very specific clinical pearl here involving surgery that examiners love.
The anesthesia danger, right?
Yes. Ascaris worms have primitive nervous systems. If a patient with an undiagnosed Ascaris infection is put under general anesthesia and given certain paralytics or broad-spectrum depolarization blockers, the worms get paralyzed too, or worse, they get startled.
Startle worms.
They become highly agitated by the chemical environment. They start migrating erratically to try and escape the noxious gas or drug. They can force their way up the biliary tree, blocking the common bile duct, causing acute jaundice or pancreatitis.
Oh my God.
Or they can migrate all the way up the esophagus and actually exit via the patient's nose or mouth while they're in the recovery room.
Waking up from surgery with a foot-long worm coming out of your nose.
It is deeply traumatic for the patient and for the nursing staff. But biologically, it is simply a stress response to the anesthesia.
What about obstruction outside the gastrointestinal tract, like in the lymphatics?
That's lymphatic filariasis caused by Wuchereria bancrofti. The mosquito injects the larvae, and the adult worms eventually migrate to and live inside the afferent lymphatic vessels. They act like hairballs in a drain pipe.
So the lymphatic fluid just backs up into the limb.
You get profound lymphedema. But it's not just the physical blockage. The host immune system reacts to the presence of the worm with intense inflammation. Over time, this leads to fibrosis and scarring of the lymphatic channels themselves.
And that turns soft pitting edema into hard woody tissue.
Exactly. Irreversible elephantiasis. The skin becomes thickened and hyperkeratotic.
And finally, in this category, space-occupying lesions. Cysts that essentially act like slowly growing tumors.
The classic example is Echinococcus granulosus, the hydated cyst. Humans are actually an accidental dead-end host here. Usually this is a cycle between sheep and dogs.
Yeah.
But if a human accidentally ingests the eggs from dog feces, the larvae migrate and form a large fluid-filled cyst, most commonly in the liver.
And it just grows slowly over years like a benign tumor.
Right. It exerts mechanical pressure on the surrounding organs. But the real danger is the fluid inside the cyst. It's called hydated sand, and it is a highly concentrated cocktail of parasite antigens.
Why is that so dangerous?
Because the host immune system has essentially been walled off from these antigens. It hasn't seen them. If a surgeon tries to just cut the cyst out and accidentally nicks the wall, spilling that fluid into the sterile peritoneum.
Massive immune reaction.
Instantaneous anaphylactic shock. The patient can literally die on the operating table in minutes. So surgeons have to be incredibly careful. They often use the para technique, where they puncture the cyst, aspirate some fluid, inject a scolicidal agent like hypertonic saline or ethanol to kill the parasite first, and then re-aspirate before attempting removal.
Another vital space-occupying lesion is neurocysticercosis.
Yes, caused by Tachinina solium, the pork tapeworm. But notice the nuance here. You get the intestinal tapeworm by eating undercooked infected pork. You get neurocysticercosis by ingesting the eggs directly from human feces.
So a human acting as the intermediate host.
Exactly. The eggs hatch the larvae, enter the blood, and they migrate to the brain where they encyst.
This is the one that looks like Swiss cheese on a brain MRI.
Yes. Multiple calcified or active cysts. And interestingly, as long as the cyst is alive and healthy, the immune system largely ignores it. The parasite suppresses local inflammation. But when the parasite eventually dies of old age, The cyst degenerates,
Yeah.
the wall breaks down, and the immune system suddenly notices it and attacks.
And that sudden massive inflammation in the brain tissue causes seizures.
It is the absolute #1 cause of acquired epilepsy in developing nations.
Okay, we have built a really solid foundation. We've covered invasion, direct damage, and obstruction. Now we are getting to the most complex part of Chapter 68, and frankly, the most important part for truly understanding chronic parasitic disease. Part 4, the double-edged sword, immune-mediated pathology.
This ties perfectly back to our introduction. The
Yeah.
host's reaction is very often what causes the actual disease. The body says, I can't kill this thing because it's too big or has a thick cuticle, so I'm going to wall it off or just attack it constantly with inflammation. And that collateral damage is the illness.
Let's talk about that walling off strategy, granulomas. This is the absolute hallmark of schistosomiasis.
This is a perfect example of mistaken identity and collateral damage. In schistosomiasis, the adult worms live inside your blood vessels. Mesenteric veins for S. mansoni and japonicum, or bladder veins for S. hematobium. And the adults are actually very, very good at hiding. They coat themselves in host blood proteins.
So the immune system basically ignores the adult worms.
Almost entirely. The adults can live there for decades, causing zero problems. The pathology is caused by the eggs. The adult pairs lay thousands of eggs a day. These eggs are spiky, and they're biologically meant to push through the vessel wall into the gut lumen or the bladder to get excreted and continue the life cycle.
But they don't all make it to the exit.
Right about half of them get swept away by the venous blood flow. If you are Schistosoma mansoni, you are in the mesenteric veins. The blood flow takes you straight to the liver.
So these spiky eggs get physically stuck in the tiny liver capillaries.
Exactly, in the presinosoidal venules. Now, the egg is not quiet. Unlike the adult, it secretes highly immunogenic soluble egg antigens. It essentially screams, I am here.
And the immune system responds forcefully.
It launches a massive Th2-mediated immune response. It calls in thousands of eosinophils, macrophages, and lymphocytes. But they can't digest the tough eggshell. So since they can't clear it, they build a cellular prison wall around it, a granuloma.
And over time, that cellular granuloma turns to hard scar tissue.
Fibrosis. Now imagine thousands of these eggs getting stuck in your liver every single day for 10, 20 years. You develop extensive pipestem fibrosis around all the portal veins. This physically constricts the blood flow through the liver.
Resulting in severe portal hypertension.
The pressure backs up. You get a massive splenomegaly fluid leaking into the beliocytes and incredibly dangerous esophageal varices that can rupture and bleed. But, and this is the highest yield mechanism for the boards, the actual liver cells, the hepatocytes, are completely fine.
Wait, really? The liver isn't failing?
No. The granulomas are around the veins, not destroying the functional parenchyma. So the patient can have terrible life-threatening portal hypertension, but their liver enzymes, AST and ALT, and their synthetic function like clotting factors remain totally normal until the very end stages.
It's purely a presenosoidal obstruction.
Right. It's a plumbing problem, not a cell death problem like you see in alcoholic cirrhosis.
That is a crucial distinction. What about schistosoma hematobium?
Those eggs get stuck in the bladder wall. The chronic granulomatous inflammation there leads to hematuria blood in the urine. And over decades, the constant inflammation and cell turnover strongly predisposes the patient to squamous cell carcinoma of the bladder.
Let's move to hypersensitivity, where the inflammation itself destroys the organ even without a granuloma. River blindness caused by Onchocerca volvulus.
This is truly tragic pathology. The black fly bites you, and the adult worms form painless fibrous nodules under your skin. The adults themselves don't cause much trouble, but they release millions of microscopic motile larvae called microfilaria that migrate constantly through your subcutaneous tissue and your eyes.
And when they are alive, migrating through the eye.
The immune system largely ignores them, but when they die naturally, it's an inflammatory bomb going off in the tissue.
So, ironically, giving a drug treatment that kills them all at once triggers massive damage.
It certainly can. We call that the Mazzotti reaction. But even naturally, as thousands of them die daily in the cornea, the host immune response causes severe keratitis inflammation of the cornea. And every time it gets inflamed, it heals with a little bit of scarring. Over years, the cornea simply becomes opaque.
Sclerosing keratitis. The patient goes blind purely because of their own immune response trying to clean up dead parasite debris.
Correct. The parasite did not eat the eye tissue. The host scarred it, trying to sweep up the mess.
We see a very similar chronic inflammation model in Chagas disease, specifically what happens in the heart.
Chagas cardiomyopathy is fascinating and very scary. Trypanosoma cruzi invades the cardiac muscle cells. Now, there are two working theories here, but the dominant one is that the persistent low-level presence of the intracellular parasite drives continuous chronic inflammation that slowly replaces healthy heart muscle with fibrosis and scar tissue.
And a scarred heart is a weak heart.
It gets flabby, thin, and massively dilated. Dilated cardiomyopathy. The heart just can't pump. Furthermore, the inflammation destroys the electrical conduction pathways leading to fatal arrhythmias. A young person in South America dropping dead of a sudden heart block is Chagas until proven otherwise.
And it attacks the nerves too, not just the heart muscle.
Yes, it has a strong predilection for the autonomic nervous system. It specifically destroys the myenteric plexus in the gastrointestinal tract.
Those are the nerves that tell the gut to contract and move food along.
Exactly, peristalsis. Without that squeeze signal, the esophagus and the colon act like blown-out tires. They just stretch and stretch without contracting. You get megaesophagus where they can't swallow, and you see a bird beak sign on X-ray and megacolon, which causes severe, intractable constipation.
Before we completely wrap up the mechanisms, we have to talk about how they survive this prolonged war. Immune evasion. Why can't we just make antibodies clear the infection and cure ourselves?
Because some parasites are absolute masters of disguise. The undefeated champion of this is Trypanosoma brucei, the cause of African sleeping sickness.
This is the ultimate cat-and-mouse game.
It is molecular genius. The entire surface of the trypanosome is uniformly covered in a single type of protein called the variant surface glycoprotein, or VSG. It's a thick, uniform coat.
So the body sees that coat and makes antibodies to it.
Right. The host immune system mounts a massive, aggressive IgM antibody attack and successfully wipes out 99.9% of the parasites in the blood. The patient's fever drops. The host thinks they have won the war.
But they haven't.
No, because 0.1% of the parasite population has performed a genetic magic trick. They have shuffled their DNA using gene conversion to express a completely different VSG gene from their internal library of over 1,000 silent genes.
They literally just changed their code.
They put on a fake mustache and glasses. The millions of antibodies the host just made do not recognize this new coat at all. So this new 0.1% population replicates freely. The parasitemia rises again, and the fever spikes again.
And the body takes a week to learn the new coat and makes new antibodies.
And as soon as it does, the parasite switches its coat again. This continuous cycle causes undulating fevers. It completely exhausts the host's immune system, it depletes complement proteins, and eventually the host simply runs out of energy and succumbs to secondary infections, or the parasite crosses the blood-brain barrier, causing the fatal sleeping sickness.
It is unbeatable by natural immunity because the parasite literally changes the rules of the game every single week.
Exactly. It's a war of attrition, and the parasite has endless ammunition.
Okay, we have built a massive, comprehensive mental model here. We've covered invasion, direct damage, obstruction, and immune pathology. Now let's bring all of this directly to the bedside. Part 5, clinical pattern recognition. This is the exam corner.
Let's start with Eosinophilia, because this is the classic parasite flag you will see on a complete blood count.
But I want to clarify something. Does high eosinophils always mean parasites?
Absolutely not. Eosinophilia is driven by interleukin-5. It is a very specific evolutionary response to invasive helminths, worms that are actively migrating through host tissue.
Explain the mechanism behind that. Why eosinophils specifically?
Eosinophils are designed for targets that are simply too big to be phagocytosed by a macrophage. A macrophage can't eat a 2-inch worm, so eosinophils attach to the surface of the worm, which is usually coated in IgE antibodies, and they degranulate. They dump major basic protein directly onto the worm to chemically burn holes in its cuticle. This process is called antibody-dependent cell-mediated cytotoxicity, or ADCC.
So if I have a protozoan infection like malaria or giardia or entamoeba, I get a massive eosinophilia.
Generally, no. Protozoa are single-celled. They're small enough to be handled by normal cell-mediated Th1 responses or macrophages. If you see profound eosinophilia on an exam question, you must think worms.
But not just any worms, right? They have to be invasive.
Right. If the worm is sitting happily inside the gut lumen, like an adult tapeworm or an adult pinworm, and it's not invading the mucosal tissue, the systemic immune system might not even see it. Your eosinophil count could be perfectly normal. Eosinophilia peaks during the tissue migration phase, like when Ascaris or hookworm larvae are actively bursting through the lung alveoli.
So the rule of thumb for test day eosinophilia equals invasive worms. Protozoa equals no eosinophilia.
That's a very safe rule to live by for the boards.
Let's talk about larva migrans syndromes. This is essentially when the parasite gets lost, right?
Yes, these are zoonotic infections. The parasite is evolutionarily adapted to infect a dog or a cat. Humans are an accidental dead-end host. The parasite enters our body, realizes it's in the wrong animal, and it wanders around aimlessly trying to find the specific chemical cues for the tissue it wants. But it never finds them.
So let's split this up. Cutaneous larva migrans.
This is usually the dog hookworm Ancylostoma caninum. It penetrates human skin just like human hookworms do, but it lacks the specific enzymes required to digest through the human basement membrane to reach the bloodstream, so it gets trapped forever in the epidermis.
It just crawls around right under the skin?
Yes. It creates a very distinct serpiginous or snake-like raised, intensely itchy red track on the foot or the buttocks. It moves maybe a few centimeters every single day. We clinically call it creeping eruption.
And visceral larva migrans.
This is usually the dog roundworm Toxocara canis. A toddler is playing in a sandbox and eats dirt contaminated with dog feces. The eggs hatch in the gut, but instead of staying there, the larvae penetrate the gut wall and migrate randomly through the internal organs, the liver, the lungs, and tragically sometimes the eyes.
And since they are constantly actively migrating through deep tissue,
You get massive systemic Eosinophilia, hepatosplenomegaly, and fever.
geography is often the biggest clue in any parasitic question stem. Let's do a really quick rapid-fire association game.
Let's do it.
Patient from West Africa presenting with confusion, personality changes, or reversed sleep cycles, sleeping during the day.
Trypanosoma brucei gambiense, West African sleeping sickness.
Patient from South America presenting with newly diagnosed heart failure or profound difficulty swallowing megaesophagus.
Chagas disease caused by Trypanosoma cruzi.
A hiker or camper in the Rocky Mountains who drank unfiltered stream water followed a week later by foul-smelling, fatty, floating diarrhea.
Giardia lambli.
Bro. Beaver fever. A perfectly healthy teenager who went swimming in a warm freshwater lake in Texas or Florida followed 3 days later by rapid onset severe purulent meningitis and rapid death.
Naegleria fowleri, the brain-eating amoeba. It enters through the olfactory nerve in the nose, crosses the cribriform plate, and literally dissolves the frontal lobe tissue. It is tragic and almost 100% fatal.
Okay, that covers the essential pattern recognition. Now we are going to put our listeners to the test.
It's time for the recall section.
Yeah.
Pure active learning.
Here is how this works. I'm going to give you a short clinical snapshot. You have to tell me the organism or the specific mechanism. I will pause for a couple of seconds so you can think it through or just shout the answer at your dashboard.
Let's jump in.
Question 1. A patient presents with megaloblastic anemia, abnormally large red blood cells, and peripheral neuropathy. They have a dietary history of eating raw freshwater fish. Which parasite is competing for a specific vitamin, and what is that vitamin? Take a second to think.
The answer is Diphyllobothrium laudum, the fish tapeworm, and it competes for vitamin B12.
Question 2. A child presents to the clinic with a rectal prolapse. Stool microscopy is performed and shows barrel-shaped eggs with distinct clear bipolar plugs on the ends. They look a bit like little lemons. What is the organism? Think about it.
That is Trichuris trichura the whipworm. Those bipolar plugs in the eggs are absolutely pathognomonic.
Question 3. You are examining a patient with severe portal hypertension. They have ascites and a massively enlarged spleen, but they have no history of alcohol abuse and no signs of hepatocyte failure. They are an immigrant from a tropical river region. A liver biopsy is performed and shows prominent granulomas surrounding embedded eggs. What is the pathogen? Take a moment.
Schistosoma. Likely Schistosoma mansoni or japonicum. Remember, the pathology here is purely driven by the host's immune response, the granuloma reacting to the eggs trapped in the presenosoidal venules.
Question 4. A patient with advanced AIDS presents with severe intractable watery diarrhea that is causing profound dehydration. A special modified acid-fast stain of the stool reveals bright red oocysts. What is the likely protozoan? Think about the stain.
Cryptosporidium. In a healthy immunocompetent person, it causes about a week of miserable diarrhea, but self-resolves. In an AIDS patient, it is chronic severe and usually requires immune reconstitution with antiretrovirals to finally clear.
Question 5. Which blood flagellate successfully evades the host immune system by constantly shuffling its genes to change its variant surface glycoproteins, or VSG? Take a second.
Trypanosoma brucei, the causative agent of African sleeping sickness. That mechanism is antigenic variation.
Question 6. Last one. A patient undergoes a colonoscopy which reveals a flask-shaped ulcer in the colonic mucosa. An ultrasound later reveals a liver abscess that, when aspirated, yields fluid described as anchovy paste. What is the organism?
Entamoeba histolytica. a tissue dissolver.
Fantastic. If you nailed those rapid-fire questions, you are in excellent shape for this topic. If not, don't worry at all. This is incredibly dense, unfamiliar material.
I strongly advise you to open Murray Chapter 68 right now while it's fresh. Specifically look at the section titled Immunopathologic Mechanisms. There's a chart explaining the difference between type 1, type 2, and type 3 hypersensitivity reactions to parasites. It is pure gold for solidifying this framework.
And take a glance at the life cycle diagrams in Gallup's Chapter 46. Actually visualizing the entry site versus the damaged site really helps cement the mental model we just built.
It really does. It highlights that parasites are truly masters of biological balance. They use mechanical pressure, they use nutrient theft, and brilliantly they use our own immune systems against us.
And it brings us all the way back to that initial philosophical thought from the beginning of the show. The ultimate goal isn't to kill the host.
Right. Just consider the long-term evolutionary cost of winning a war. If a pathogen is too aggressive like Ebola, it burns through the host rapidly. The host dies and the pathogen dies with it. That is a failed evolutionary relationship. The perfect parasite is one we never even notice. It takes just exactly enough to survive, but not enough to trigger an eviction notice from the immune system.
So maybe the absolute most successful parasites on Earth are the ones we haven't even discovered yet because they are just so incredibly good at being quiet squatters.
That is definitely a thought to keep you up at night.
On that very comforting note, keep studying the host-pathogen chess match. Thanks for listening to this deep dive.
See you next time.